So the bone health optimization, the patients usually are on some form of medications in any case. And when you convince them, it takes a long time and they're convinced. And then you say, wait for 3 months and 6 months in your practice. Would you think it's a very practical? And what are the long-term data on this?
So there is a lot of data to suggest, and it was mentioned that there's higher incidence of periprosthetic fractures in these patients, and you can experience that yourself also. I'm sure you have come across patients where you can actually end up fracturing.
So patients quite disabled, painful.
Yeah. So the question is that you are only treating those who are at risk of fractures intraoperatively, and it is now becoming a standard to assess bone health before doing an elective surgery in a patient in order to avoid complications. Now, if your patient can't wait, it doesn't matter. What we do is, if a patient is from another city, you can give them, zoldronic acid injection before you discharge them. The idea is that you have to be aware about it and you have to treat it.
And that's fine.
Okay, microphone. Microphone. Oh, another comment. Yes.
Yeah, my take is that if the patient is coming up for surgery and we have decided everything else, at least what Rajesh has rightly mentioned, that you can pinpoint that this patient will need a additional support of various medicines like teriparatide and denosumab. Immediate postoperative period itself.
Okay, thank you. Microphone 2.
Yeah. Bipolar hip in a fractured neck or femur, I prefer a ceramic head. So these bipolars don't work like unipolar in first 6 months. All bipolars work like unipolar, and that is why the protrusion occurs.
Right.
Once you put a ceramic head inside that instead of steel, the friction is so less that it allows more mobility, less dislocation.
Okay, so
what is your kind opinion?
So you think ceramic against polyethylene has lower friction than cobalt chrome against polyethylene, so it's more likely to articulate at that inner bearing. Anyone have a comment on that?
Two things. Number one is they have shown that monopolar and a bipolar do not have any difference in the long-term outcome. I haven't included a couple of papers which I wanted to hear, and these papers found that the people who are selected for hemi replacement are they are older with more comorbidities, and almost 80% of them are dead within next almost 5 to 7 years. 80% are no more living. So we are not looking at the wear rate at 10 and 15 years. And their activity is, most of them are housebound. They don't have excessive outdoor activity. So if you ask me, it really doesn't matter which type of head you use inside, because if the monopolar is same as bipolar in terms of longevity and function, what difference does it make which head you use?
So you don't think it matters? You got another question?
Another question.
Yes. Okay.
In that dysplastic hip, somebody showed an X-ray, but the cup was elevated more than 1.5. I was taught by Dr. Ranawat Senior that don't allow your cup to go more than 1 centimeter from the teardrop line.
In a dysplastic hip, how high can you raise the hip center? Is there a limit of 1 centimeter, or he says that was 15 millimeters, that one?
We've published on this. The wear rates and fixation with non-cemented fixation is absolutely fine. You can go 1.5 to, that cup was placed in the absolutely perfect position. And so there's no problem there with fixation or wear rates with.
So I've got a question for you, Amar. If you raise the cup then and you match it with chasing it with the femur, in extension, you might be able to equalize leg length. But when they flex, then your lengthened femur is now pushing against the cup. The cup's not posterior. So does that cause stiffness? If you raise the hip center too much and chase it with the femur, does that cause stiffness? Because I've seen stiffness when we've raised it a lot. They can't bend. They bend 60 degrees and they can't go any further, you know.
Well, she probably couldn't bend her hip, 60 degrees before that. So there's lots of factors that come into play with regards to their motion loss. But the point is to get that hip reduced appropriately and not get her a nerve injury. And you do that by raising the cup where it is. But as I said, we've shown that it doesn't affect wear or fixation.
Okay.
But you make sure you don't lengthen so much you lose flexion. So you maintain the flexion and compromise between the two.
Yeah, I think there's, in my mind, there's a limit with flexion and stiffness if you go too high, because you're only looking at it on the coronal plane and extension. Okay, so next question, I think microphone 1.
Question to the panel regarding the pre-op hip spine evaluation. Are you currently doing a forward flex deep sitting X-ray or just a straight spine sitting X-ray?
Yeah, that's a good question, because in North America, they just do X-rays often just of the L5, S1, and just standing and relaxed seated. In Australia, we do L1 to the pelvis, and the flex seated view gives you more information about the stiffness of the lumbar spine. So is the relaxed seated view enough? Is L5, S1 enough, or do you get more information by going to L1 and doing a flex seated?
We do the flex seated.
Yeah, and do you go to L1, or do you go all the way to the top of the lumbar spine, or do you just go, yeah. Yeah, we do the same thing. Any other comment? David, are you moving more towards getting those other views?
I think we'd get more information with a flex seated view. We traditionally get a relaxed seated view. We get right to the top of the lumbar spine,
yeah,
but just with a relaxed seated view.
Okay.
I think the hip-spine relation is overstated. Whatever analysis you do, end of the day you are able to dial only 10 degrees antivation or retroversion.
So you think it's overstated, the importance of...
Especially in India.
Yeah.
So I think Amar made a good point before, is what we're trying to do with this is identify the patients at risk, right? Most of the patients in the middle, they're fine. But it's identifying the patients at risk.
And really tough patients, I think technology-enabled hip replacement can make the difference of a few degrees also.
Well, that also remains a fact that the surgeries done before we started assessing the spinopelvic parameters, the dislocation rate was not very high.
Yeah.
But maybe we will be able to identify some high-risk individuals in these cases.
Okay, there's a question at microphone 4, then we'll come to 2.
Good morning. I'm Dr. Suman Babu Maratha from Nepal. My question to all the panelists is, in case of ankylosing spondylitis involving bilateral hip joints, as the case shown, would you like to do the surgery at the same sitting, or would you like to stage the surgery, considering the post-op rehabilitation?
Good question. Bilateral.
We have been doing bilateral total hip replacement in fit patients quite regularly. So depends on lots of patient factors, your team. So if you have a good team, good host in the sense that the patient is fit enough, then we do bilateral total hip. And its posterior approach, I will do bilateral. If it's DAA, we will do bilateral.
So the problem is that if you have bilateral stiff hips and you do one, they still can't sit, and there's a high risk of dislocation in the replaced hip. So we have cases like that. So I mean, it's always advisable if the patient, because these are young patients, so if you've got a good anesthetist, you should try to do them together.
Okay.
We do it 3 days apart.
3 days apart.
Because we want to make sure that the patient is, because most of the time these
resuscitate,
patients are,
resuscitate them with blood or whatever they need. Yeah.
With the Angspon, it is still single ream with the robot, a few steps.
So do you do Angspon with the robot? Do you do single ream?
But as you mentioned, I changed the technique.
Okay.
I'm still, I downsize the reamer.
Downsize
I make
the
sure that I have got good, I'm reaming centrally, and then I will go down to the appropriate reamer. So 2 reams.
2 reams.
Instead of 1.
I don't see any reason why it can't be a single ream in bony ankylosis. If I have any problem, I'll take an image intensifier as well when I'm reaming. But I think that makes no difference whether it's fused or not, if you planned it well.
Can I just make one comment?
I'm a bit scared than Dr. Manoj.
People use image intensifier on the hip. Maybe it is okay to see the depth, maybe okay to see maybe inclination.
Yeah.
But it's difficult to judge your version.
Yeah.
And on table, when everything is sterile, you are draping everything and then trying to get a siam in, especially in lateral position, it's not so easy. Okay. So I don't think image will give you a lot of good information apart from maybe depth at which you are aiming.
Okay, yes, microphone 2.
David, you have shown that you try to retain the piriformis when you are doing a posterior approach. So what are the specific advantages of retaining the muscle, and how easy or difficult is it to dislocate the hip?
Yeah, so I've been doing it for about 2 years now. When I first started, I started with thin, flexible people and thought this is going to be really hard to do in that BMI 40 stiff male. It's actually not all that difficult. So I find the piriformis. I actually dissect between the piriformis and the minimus, which makes the piriformis muscle a little more mobile.
Okay.
You typically, when you do the exposure, you see the inferior half of the head. It's not difficult to dislocate. Sometimes it's difficult to move the femur anterior, and if it's difficult to move the femur anterior, from inside I actually release the superior capsule. And if you release the superior capsule, then it's pretty easy to move the femur forward. But I thought it was going to be difficult to maintain the piriformis. It's not. The other advantage of keeping it is it protects the gluteus minimus from your retractors. So you now have a thick band of tissue, so if you've got a retractor pulling anterior or superior, it actually protects the minimus from damage.
But regarding post-op dislocation, any changes?
So the one thing I've changed now is I have no posterior hip precautions at all. I just tell people no aggressive stretching in the first 6 weeks, but other than that, no posterior hip precautions.
So, David, any difference between varus and valgus femoral necks?
So it can be a little bit more difficult in the varus femoral neck because the piriformis can be a little bit more horizontal. Again, I was worried about it when I started, and it just hasn't been an issue.
Okay, good. Thanks. We'll go to microphone 1. Thank you.
My question is regarding the short versus the long stems, like actis or the trilog stem. How do you choose where you going to use the short stem or long stem, and what type of patients? Number 2, if you are using collared stem, if the collar is up, what is the use of using collared stem? If it is up the bone, the gap is there.
So what about all these new stems that are taking the market by storm in the US? Why are people choosing them? Do you selectively use them?
As Dr. Malhotra has mentioned, lots of stems have made a reappearance because of the approach that is being more popular. So with the advent of direct anterior approach in the US and probably in Australia as well, people want, and if it's a blade kind of a stem, by using a DA, you get a little bit of front to back movement. So these stems become loose, and to get more stability, people are going for bigger sizes, and that is causing periprosthetic fractures. So I think collar has made a comeback from that point of view, and as he's mentioned, most of the people are now moving for collars, reducing the periprosthetic fracture risk. I have also shifted to an extent. Unfortunately, in our country, those new stems are a little bit more expensive than the standard stems, which have really worked well for the past 20 years. So I would not push for somebody to change to a new expensive stem just for the heck of it.
Okay, we've got a couple more questions, so I might keep going.
A quick question to Dr. David. David, you said you retained the piriformis. There are some studies from Australia also concerning the piriformis being retained, and at the end of the procedure it's become stretched and it becomes not a functioning muscle at all. And so what are your thoughts on that, number 1? Number 2, what would be your cutoff? Like, see, we deal with a lot of stiff hips, a lot of hips that have significant fibrosis, and it definitely is difficult to dislocate. So would you have a cutoff where you will not retain the piriformis, you will go ahead and cut it and then proceed to a standard posterior?
Yeah, so my first comment was whatever you do, do it well. My second comment will be make sure that you have good exposure when you're doing a hip replacement. So you should not sacrifice your vision. Right? If you need to take the piriformis in order to get a good exposure, then absolutely you should take the piriformis to get a good exposure. I always start now keeping it, and then I would release it if I needed to release it. I just really haven't seen that so far. In regards to your first question, it's a great question. We're actually just about to start an MRI study looking at these patients 6 months post-op to look at the condition of the piriformis, because that's one of our concerns as well.
Another question, microphone 2.
One question, boss. In ankylosing spondylitis with a spine deformity and a hip deformity, I did bilateral total hip.
Yeah.
She was very happy.
Yeah.
Went away. After 2 years, she came for the spine.
They changed the angle of the spine?
Yeah, I changed the angle of the spine and the hip started squeaking.
Oh, okay. So she had a kyphosis and they straightened the spine up, so it rolled your pelvis forward and changed it. So
and then I told her, I was also upset. I said, are you willing for a revision surgery? She said no. She went back, gave a thought. After 3 months she calls me, doctor, my squeak has disappeared.
Okay. So what if...
If
you've got ankylosing spondylitis with a spinal deformity, do you have to consider that might be corrected in the future for your cup position? And how would you deal with that?
You know, I think it's an interesting...
One hip, huh? Not both. One hip started squeaking.
Yeah, no, listen, I think the real question of, are we going to anticipate what the spine is going to do in the future? You can't really do that, you know? There are some deformities where we'll nowadays consider doing the spine first before we do the hip, but it's still pretty rare that we're going to do that. We just have to deal with the problem as it arises. So if the hip starts dislocating, you have to deal with it. If the hip starts squeaking, you know, you have to deal with it. Your problem went away, so you didn't have to deal with it. That's the reality of the situation.
Okay, that's great. We're going to conclude there. Thank you all to all the panel for an excellent session.